Thank you once again for the opportunity. I would be presenting role of Amivantamab in NSCLC patients with MET exon 14 skipping mutation. This is a cohort in Chrysalis study. We had a great discussion yesterday regarding EGFR subset. So as we all know that Amivantamab is EGFR MET bispecific antibody, and it has demonstrated activity in EGFR exon 20 insertion mutation post progression on platinum doublet with response rate of 40% and duration of response of around 11 months. This we discussed yesterday. Being a bispecific antibody, it has shown activity even in TKI resistant EGFR mutated as NSCLC, especially the ones who had MET amplification. As we all know that MET amplification is a resistant mechanism, especially in post third generation TKI. So here, based on the pharmacokinetics, the Amivantamab drug had higher affinity to MET than EGFR, and it was shown that there was depletion of free soluble targets when adequate dosing was done. So they evaluated it in primary MET driven tumors, and I would be presenting that subset. As we all know, MET exon 14 skipping mutation is around 3% of our NSCLC. They are generally seen in older population. As we saw in the previous study also, the average age is around 70 years, median age. It is seen more in women, more in non-smokers. MET TKIs are approved. They have accelerated approval, capmatinib and tepotinib. They are available also. With overall response rate around 41 to 43% in previously treated and MET TKI naive patients. Most patients will develop resistance to these drugs and will progress. So now I will be discussing the Chrysalis phase 1 study regarding MET exon 14 population. So it was in two phases. Part 1 was dose escalation, where they started from 140 to 1750 milligram of the dose, and the dose expansion cohort, the dose selected for phase 2 was, part 2 was 1050 milligram if less than 80 kg and 1400 milligram if more than equal to 80 kg. And MET2 cohort, they have recruited around 55 patients, and they're planning to do it up to 100 patients. So metastatic or unresectable advanced NSCLC who have failed or ineligible for standard of care therapy were eligible, and they have to have measurable disease in primary MET exon 14 mutation by NGS or ctDNA from tumor tissue or ctDNA. So this is the demographics. As we can see, even in previous study, the median age is around 70 years, be it treatment naive or patient exposed. So out of the 55 patients, around 9 patients were treatment naive. Around 18 patients had no prior MET inhibitor, but they have received some form of treatment. And around 28 patients had prior MET inhibitor. So this was given post MET inhibitor progression. So in the second and third cohort, we can see that median lines of treatment is 1.5 and 3 respectively. We can also see that around 10% of the patients, around 18% of the patient, 10 out of 55 had history of brain mets. So this is the response rate plot. Here you can see that in treatment naive patients, 4 out of 7 patients responded with partial response with overall response rate of 57%. In patients who had no prior MET inhibitor, it was 7 out of 15, again overall response rate of 47%. In patients who were exposed to prior MET inhibitor, it was 4 out of 24 with response rate of 17% only. So if we take the whole cohort, the response rate is around 33%. Of the 15 patients who responded, 11 patients are having ongoing response, and 10 out of 15 patients had response duration of more than 6 months. So this is something which suggests that there is activity of this drug in this subset of patient. If we consider stable disease also, so clinical benefit rate is around 59% for the whole cohort. For treatment naive, it is 71%. For patients who have not received prior MET inhibitor, it is 53%. And patients who have received prior MET inhibitor is 58%. Median PFS for the whole cohort is 6.7 months. For treatment naive, it has not reached. For patients who didn't have prior MET inhibitor is 8.3, and the ones who had prior MET inhibitor is 4.2 months. Median time to response, as with many TKIs, is less than 2 months. Safety profile, we had a good discussion yesterday regarding the infusion reactions, the skin toxicity, rash, dermatitis, paronychia, stomatitis. So there is some risk of pneumonitis involved. ILD was around 4% in this patient. So overall, the safety profile was similar to the larger Chrysalis group. There were no special toxicities in MET exon 14 group, which we didn't see in EGFR. This drug required interruptions in 21% patients, dose reduction in around 12% of the patients, and discontinuation in 5% of the patients. This is for the whole Chrysalis cohort and not for just MET exon 14. So the preliminary results suggest that amivantamab monotherapy has activity in MET exon 14 NSCLC, and it looks similar to MET TKIs. This is just an assumption based on overall response rate in small number of patients. Anti-tumor activity in patients who responded was durable. So 11 out of 15 patients continue to respond, and around 67% of the patient who responded has response duration of more than 6 months. Safety profile is consistent with what we see in EGFR exon 20 mutation or in the larger Chrysalis trial. And MET exon 14 confirms independent targeted actionable mutation, and it looks like amivantamab has a role even in this cohort of patients. Thank you.